Hello and welcome to the topic of other types of diabetes in the endocrinology module. The other types of diabetes that we'll be discussing in this topic would be maturity onset diabetes of the young or MODY and latent autoimmune diabetes mellitus in adults, also known as LADA. So by the end of this topic, you should be able to define MODY and LADA, explain the pathophysiology of these two conditions, outline the causes and classifications of MODY and LADA, describe the clinical manifestations, outline the investigations that are done, and discuss the principles of management as well as discuss the complications and prognosis of MODY and LADA. Let's get started. In this session, we'll be focusing on maturity onset diabetes of the young as well as latent autoimmune diabetes in adults. So let's begin with the terms. MODY is a group of monogenic disorders that is autosomal dominant and is a non-insulin dependent form of diabetes, classically presenting before the age of 25. LADA, on the other hand, is adult onset diabetes, which has features similar to both type 1 and type 2 diabetes mellitus. LADA resembles type 2 diabetes mellitus in the sense that they do not require initial insulin treatment, but they do have immunogenic markers associated with type 1 diabetes, primarily the anti-GAD antibodies. Before diving further into the pathophysiology of these two conditions, let's understand the normal physiology of how insulin functions in the body. As we know, insulin is a crucial hormone that regulates cellular energy supply and macronutrient balance, directing anabolic processes of the fat state. Insulin is actually important for the intracellular transport of glucose into insulin-dependent tissues such as adipose tissue and the muscles. What happens is there will be a signaling abundance of exogenous energy, breaking down adipose fat tissue and promoting its synthesis. In muscle cells, the entry of glucose allows glycogen synthesis and storage, and for carbohydrates to be used as the immediately available energy source for muscle contraction, rather than fatty acids or amino acids. Therefore, in short, insulin promotes the synthesis of both glycogen and lipid in muscle cells, while it suppresses the lipolysis and gluconeogenesis from amino acids in the muscles. In the presence of adequate amino acid supply, insulin is anabolic in the muscle. Insulin resistance, on the other hand, is when there is impaired biological response to insulin stimulation to the target tissues, primarily the liver, muscle, and adipose tissue. As a result, glucose disposal is impaired, leading to a compensatory increase in beta cell insulin production and hyperinsulinemia. This may also result in hyperglycemia, hyperuricemia, hypertension, dyslipidemia, visceral adiposity, a prothrombic state, endothelial dysfunction, and elevated inflammatory markers. Let's now understand the pathophysiology of MODY and LADA. Let's begin with MODY. So generally, MODY is due to an ineffective insulin production or release by pancreatic beta cells. As mentioned previously, this is an autosomal dominant disease where there are several forms of defects to the transcription factor genes, and one form of mutation is due to a mutation in the glucokinase gene. Just remember, for each form of MODY, there will be multiple specific mutations occurring that involve different amino acid substitutions. In some cases, there will be significant differences in the activity of the mutant gene product that contribute to variations in the clinical features of diabetes, for instance, age of onset or degree of insulin deficiency. Moving on to LADA, this is similar to type 1 diabetes in where patients will display autoantibodies indicative of autoimmune pathogenesis. However, the autoimmune pathogenesis will be in a milder form with a slower progression of beta cell failure. Thus, LADA patients will consistently have higher levels of C-peptide as an indicator of insulin secretion. In addition to that, these patients are not insulin requiring for some time following diagnosis. Interestingly, those patients with LADA have less insulin secretion and progress to insulin dependence faster compared to patients with type 2 diabetes mellitus. Now, we will go over the causes of MODY and LADA. So MODY is genetic, in which the disease is inherited in an autosomal dominant manner where there will be a mutation in a gene disrupting the insulin production. This is different from type 2 diabetes since individuals diagnosed with MODY will very often have a family history of diabetes in successive generations. This means that if your grandparent or on your father's side has MODY, your father will have MODY along with yourself. As both with type 1 and type 2 DM, the risk of LADA is dependent on both genetics and environmental factors. The genetic factors for LADA would be similar to type 1 DM where the HLA complex is affected. However, genetic variants associated with type 2 DM were also found in LADA patients. Environmentally, you would consider lifestyle risk factors such as those seen in type 2 DM, like in physical inactivity, obesity, the consumption of sweetened beverages, and smoking. Both MODY and LADA can be classified into subgroups. MODY is classified into 6 subgroups depending on the transcription factor gene mutation. MODY 1 involves mutation in the hepatic nuclear factor 4 alpha gene. MODY 2, on the other hand, occurs when there is a mutation in the glucokinase gene with a likely onset during early childhood or coincidentally. The patient would experience mild hyperglycemia and diet therapy alone is sufficient. However, the complications are also rare. Next, we have type 3 MODY, which involves a mutation in the hepatic nuclear factor 1 alpha gene. The patients will experience severe hyperglycemia in which oral hypoglycemic agents and insulin are often required. There will also be a risk of high microvascular complications. Moving on to MODY 4, 5, and 6, and these are all rare forms with a postpubertal onset. Next, LADA can be classified into 3 categories, depending on their C-peptide values. Patients in category 1 have got a C-peptide level of less than 0.3 nanomoles per liter and they would be treated with intensive insulin regimens. Those falling into category 2 have got C-peptide value between 0.3 nanomoles per liter or more and 0.7 nanometers per liter or less. They will fall into a gray area, which means they would either need insulin or wouldn't. However, you may need to follow them closely as they have antibodies and low C-peptide levels. Lastly, patients in category 3 have got a C-peptide value of more than 0.7 nanomoles per liter. We will now discuss the clinical manifestations in both MODY and LADA, starting with the symptoms. In MODY, patients will present with a strong family history of diabetes. It may be any type of diabetes, and the onset of the symptoms is usually in the 2nd to the 5th decade. In some forms of MODY, patient will have significant hyperglycemia symptoms and would typically have the classical symptoms of diabetes, which are increased thirst and urination. They may also complain of unexpected weight loss and recurrent skin infections. However, many people with MODY have no symptoms or signs and they are usually diagnosed by accident when a high glucose level is discovered either when testing is done for some other reason or during screening. In LADA, the symptoms would be similar once again to the other forms of the diabetes, which would be excessive thirst and excessive urination. There are also often complaints of blurring of vision. Compared to juvenile type 1 diabetes, symptoms of LADA develop comparatively slowly over a period of at least 6 months. Now, moving on to the investigations to order. In patients suspected of MODY, you would need to order blood tests which should include blood glucose levels, HbA1c, and beta cell antibodies, for example, GAD antibodies if available. If the glucose levels are more than 15 millimoles per liter, you will need to check the capillary ketones, but they should typically be negative in the case of MODY. Another useful test for those on insulin would be C-peptide levels, and this will indicate any endogenous insulin secretion that become negative in type 1 DM after the honeymoon period, which is the first 1 to 3 years after diagnosis. In patients with MODY, the C-peptide level remains in the normal range and the beta cell antibody levels should be negative. Making the correct diagnosis of MODY is very important, especially with regards to genetic counseling and the prevention of developing the disease due to its mode of inheritance. Next, let's see what investigations we need to order for LADA. A fasting blood sugar level of 7 or more is used in the diagnosis of diabetes here. Typically, there are no clear guidelines for the diagnosis of LADA, but the criteria that are often used would be that the disease developed in adulthood, in which patients would not require insulin treatment for the first 6 months after diagnosis and would have the presence of autoantibodies in the blood. Therefore, a glutamic acid decarboxylase autoantibody, which is GAD antibody, islet cell autoantibody ICA, insulinoma-associated autoantibody, and zinc transporter autoantibody testing should be performed in order to correctly diagnose LADA. Those with LADA usually have low, although sometimes moderate, levels of C-peptides as the disease progresses. In the case of MODY, the main goal of treatment would be to keep the blood sugar as close to normal as possible, while minimizing other vascular risk factors. Generally, the tools for management are pretty similar to all forms of diabetes, which would include blood testing, changes in lifestyle such as diet and physical activity, oral hypoglycemic agents, and insulin injections. In the majority of the patients, these goals are easily achievable compared to those with ordinary types type 1 and 2 diabetes mellitus. Do remember that some patients with MODY may require insulin injections to achieve the same glycemic control that another person may attain with lifestyle changes or oral medications. Unfortunately, there are very few studies available on how to treat LADA. This may be due to the fact that it is difficult to classify and diagnose LADA, and just bear in mind that LADA patients would often not need insulin therapy immediately after being diagnosed because their own insulin production would decrease at a slower rate than type 1 DM patients, but in the long run, they will eventually require it. And it was found that approximately 80% of all LADA patients who were initially misdiagnosed with type 2 or who had GAD antibodies will become insulin dependent within 3 to 15 years. In some forms of MODY, the standard treatment is appropriate. However, there are some exceptions. In the case of MODY 2, oral agents are relatively ineffective, but most patients are managed conservatively through diet and exercise instead. In MODY 1 and MODY 3 patients, sulfonylureas are usually very effective, delaying the need for any insulin treatment. Whenever there is a need for the use of oral hypoglycemic agents in MODY, sulfonylureas are considered the first drug of choice. Interestingly, MODY patients are often more sensitive to sulfonylureas compared to type 2 diabetic patients, and thus a lower dose should be used initially to prevent any hypoglycemia. Treatment for LADA would be the use of exogenous insulin to control glucose levels, prevent further destruction of residual beta cells, reduce the possibility of diabetic complications, and prevent death from diabetic ketoacidosis. When it comes to long-term complications of these two conditions, cardiovascular disease, nerve damage, kidney damage, eye damage, which is retinopathy, foot damage, skin conditions, and hearing impairment as well as Alzheimer's disease are common in both. The affected patient will develop renal dysfunction by 45 years old, and half of these patients can progress to end-stage renal disease without developing diabetic kidney disease. Let's summarize what we have covered so far. So MODY is an autosomal dominant group of monogenic disorders characterized as non-insulin dependent form of diabetes that is classically present before the age of 25 in adolescents or young adults, while LADA is an adult-onset diabetes with shared features of type 1 and type 2 diabetes, not requiring initial insulin treatment, but has immunogenic markers associated with type 1 diabetes, primarily anti-GAD antibodies. MODY is due to genetic mutations of transcription factors, and LADA is an autoimmune disorder influenced by both genetic and lifestyle factors. The clinical manifestations of both forms of diabetes would include typical hyperglycemia signs and symptoms, as well as unexplained weight loss and recurrent skin infections. Investigations-wise, the main test to order would include blood glucose levels, HbA1c, beta cell antibody levels, especially GAD antibodies, C-peptide, and specifically in the case of MODY, genetic molecular testing. The principal treatment goals for people with MODY would be managing good glycemic control while minimizing other vascular risk factors. Generally, the tools for management are similar for all forms of diabetes, which would be blood testing, lifestyle modifications, oral hypoglycemic agents, and insulin injections. We have come to the end of this topic. Thank you.